Hello, hello. What's up, fertility fam? Thank you for joining me live for this live watch party. If you're on the replay crew, drop a blue heart in the comments so that we know you watched it on the replay. Let's start with the intro. This watch party is going to be the watch the video of me being cleared for my FET. If you don't want to hear my commentary on it, the regular video without the watch party will be posted later. I know some of you guys like the shorter streams, so we're gonna, give everybody what they want, give the people what they want. All right, let us start with the intro, and then we will get into the video. What's up, fertility fam? Let's get these babies, ladies. To make those rainbows in my mind when I think of you. All right, you guys can hear me, right? Let me just check the comments. Who is here? Pretty Brown Eyes. Hello. Hey, Latundra. Hey, Kitty. Hey, Jennifer. Sophia. Hello, Melanie. Michelle's Piece of Life. Brittany. Hey, girl. Hey. And Michelle's Piece of Life. I'm glad you got the notification. Okay, so just as context for those of you guys before we get into this video, actually, let me just put myself in here before we get into this video. This is, I'm looking for my chapstick. I don't know where it is. This is going to be me breaking down my protocol. I know we've done it in a couple of videos, but this is all together. And then I'm going to talk to the doctor. I have some thoughts about the doctor. I want to know what you guys think, what your opinion is, because I felt like, well, I'm not going to give it away. We're gonna get into this. Here we go.
How are you?
I'm well, thank you. Nice to meet you. I am cleared to start my FET. What's up, fertility fam? Let's get these babies, ladies. Thanks for clicking on Simply Tanika. I am Tanika. If you are new here, welcome. If you are returning, welcome back. What's up, sis? What's up, fertility fam? All right, I have lots of notes everywhere, and I have puppies who think I'm playing with them. Okay. So I am cleared to start my FET, meaning not the blood work, but let me say that right. I'm cleared to start the process for my FET, not in this cycle, but next cycle. Of course, I got to have blood work and all that in the actual cycle. But as far as from the reproductive immunologist, I talked to Dr. Vidali at Braverman, who it's his sort of practice once Braverman passed. Anyway, I talked to him today. I'm all clear. I have notes, because you guys have asked me different questions and I've kind of talked about it in some videos. So we're going to make this video and it's going to have all of what's happening with me and the results of my reproductive immunology testing. Okay, so let's first and foremost, what did they test me for? A lot of you guys have asked me that. So let me give you the rundown. Because I know some of you said, I wonder if I can have my OB test me for this. I don't know, girl. I don't know. But I'm going to tell you what they tested me for. So the first, and they're in groups. So the first group is maternal immune tolerance. And it's maternal KRR, uterine NK cells, natural. So really quickly on this part, because I don't know if I said it in another thread, the test company that's doing the test is called Pregmune. And I did not find out until after I had already taken the test that the doctor actually founded this company that makes the Pregmune test, and it includes all of these. So if you're looking for like a shortcut to get to these tests, it's called Pregmune. I'll put the link actually in the oh look, it's not coming up. I should have done this earlier. Pregmune immunology testing. Here we go. So it was actually created. I'm putting it in the chat for you guys. It was actually created. And and for those of you guys on the replay crew, I will put it in the description for the video because I haven't done that yet. And while we're on a break, I just say hi to everybody else. Red Blonde Chick, hello. Runny Howard, hello. B Black. Oh God, is it Tania? Tanya? I always butcher it, but hello, sis. How are you? So yeah, that's what's going on there. All right. Back to our regularly scheduled programming.
Natural killer cells, haplotype. I'm at higher risk for that. HLA, homozygosity, HOMOZYGOSITY, homozygosity. I'm at lower risk for that. Anti-HY immunity, medium risk, and anti-HLA antibodies, medium risk. I did record what I talked to the doctor today, so stick around to the end so you can see like why I have certain medications that I have, and hopefully it'll tie it all together for you. The second grouping is female assessment, chromosome analysis, thrombophilia, it's either philia or philia, autoimmunity, which I have a medium risk for that. The thrombophilia, I had a lower risk, and the chromosome analysis was normal. Autoimmunity, I just said that, medium risk. Thyroid, lower risk. Serological,
hey Laura.
Lower risk. Inflammatory was medium risk, but when I talked to the doctor, he said he wanted to treat it as high because I've had 3 miscarriages and 4 failed transfer, well, totally 5, but 4 last year from the frozen. And then metabolic, I had a lower risk. And then nutritional analysis, I had a medium risk. So I'm supposed to be eating like a not low fat. Oh my God. Low inflammatory diet. Okay.
And I do want to say, because I know some of you guys were like, oh, should I get tested? I think I would not have tested had I not had the 4 failed, right? So I've had 5 failed transfers, 4 with the donor egg embryos. So I would not pay for this test unless it was my last resort. I feel like this is the sweet spot we were kind of talking about before, of like when we were talking about fertility coaches, is like, what is the point of desperation and what is the point that makes sense for where you are? And I just quite honestly, what I feel is like I'm at the point of desperation. Like I'm not making just foolish mistakes, but I'm spending money, right? At this point, it's like piss or get off the pot. So I think if you've had failures, then it makes sense to do the immune testing. But if you haven't, you probably have a good percentage of success without it, right? But of course, IVF is never 100%. I want to say that because I know some people in the replay crew from our last live watch were like, oh, but there's no guarantee. That is absolutely right. So if you are going through failures, I just want to encourage you to keep the faith, try and stay positive. Easier said than done. Trust me. I know, sis. I know. But the thing is, for not one person is IVF 100%. You're already having issues, which is why you went to IVF in the first place. But I do feel like, and I know this kind of contradicts, but again, this is just my emotional brain. Like, had we taken these tests, I don't know, while we were waiting, I don't know. There's a part of me that wonders. And what you'll hear the doctor say, in and of itself, some of these things don't seem to be high risk, but because I've had the losses, I've had the 3 miscarriages, I've had 5 failed transfers. Because of that, it's like we're throwing everything in the kitchen sink in, right? So it's not necessarily indicated for everyone. what does that say? Like me and forget to like when I entered. Oh my God. Do be like me. Oh yes. Everybody hit that like button on your way in. Replay crew, you too. Okay, let's get back to this. What am I talking about over here?
So the maternal KIR, or uterine NK haplotype, that was what came up high for me.
Hey, S. Willie.
Then there's a bunch of other tests. Like I said, I'll put it in the doctor's call. He will explain it to you better than I can explain it. I do want to look at the thrombophilia, though. Wait, let's see. Is that the one that was a lower risk?
Thank you, Tanya.
Pay attention, Tanika. So actually, let me go back. The one they're looking at is the natural killer cells, anti-HY immunity, anti-HLA antibodies. So what Dr. Vidali had said is mine are borderline, but because of the losses, they're going to treat it higher. Like I'm a higher risk. So the HLA and the anti-HLA active immune, they originally wanted to do IVIG, but there was this big rigmarole with the insurance. It's not going to fly. So we are doing Plaquenil. He said it's just as efficient. The IVIG I would have done 2 weeks before my transfer. The Plaquenil or hydroxychloroquine. Oh my God, I always want to say another medication. The hydroxychloroquine has to start 30 days before. So I did start that on July 1st because I was like telling myself yes before the doctor told me.
This I just want to highlight real fast. Laura, so you said, I really think I need to look further into possible immune issues myself as to why I keep miscarrying. My insurance is good, but lab testing for me can get pretty expensive. Yes, I would just, anybody who's had multiple miscarriages, I think you have to start exploring, like, why are these losses happening, right? There's probably just something that needs to be tweaked. This reproductive immunologist does not take insurance at all. Like, you can submit for reimbursement, which I did, and I don't think I've actually gotten a reimbursement. I don't think it's going to be eligible because it's basically like how they describe it as more like maintenance fees or consultation fees, something similar to that. Because they're basically, they took my lab work and then came up with this plan for me. And I want to say, oh my God, I want to say it's like $4,000 all in. It was $2,000 for the test. I believe I got $1,000 off by being X amount, like say the first 100 people or whatever who took this test. But again, they did not disclose to me that it was their own test or that it was created. Not that they have to, but then like one of you guys told me how I felt about it. And I was like, oh, I didn't even know about it. So I had to look it up. And sure enough, the doctor who you'll see later on his like LinkedIn, it says he's CEO of this other company. But I think, Laura, like, because they can be expensive, start with the basics first. If you haven't already done that, like TSH or thyroid or prolactin, vitamin D, those sorts of things, as they would be cheaper. If you've already done it, then yeah, it's time to go to immune testing more likely than not. But hopefully it's like a simple thing, like a straightforward test they can do for you. And then the next one is your take-home baby, right? We all want our take-home baby.
Yes. So I'm out, as of obviously August 1st, that'll be 30 days or 31 because July is a 31-day month, but you know what I'm saying. So let me just go through maternal KIR haplotype, the higher risk for uterine NK cells. What you need to know: uterine natural killer cells secrete a unique repertoire of cytokines and growth factors that regulate blood vessel growth and development, also known as spiral artery remodeling. And basically, what were his notes on that? So this is I remember now. This was a receptivity issue. So this secretion is modulated based on the type of interaction, activating or inhibitory, taking place between your KIR receptor present on the surface and the HLA-C of your embryo inherited from both partners. So it's receptivity. He said it's more likely that, in a long convoluted way, because I already have a child, I'm in a different category. If you haven't already had a child, it may be different for you. So we obviously know that I can carry. But he was saying even if everything was fine with me, there might be something in, because it's my own body, right? It's not necessarily inclined to attack it.
I also want to say, even though I did have a live birth, it was a very high risk pregnancy and it was very complicated. I think I've shared that at least 1 million times on the channel. But it's not like if I just had a straightforward birth and everything was hunky dory. That was not the case. It was very, it was high risk. She had intrauterine growth restriction, and there was, hi Kay, how are you? It was like, go to the hospital now. Do not pass go. We need to check you in because we're getting a very faint heartbeat and very low movement, which because she was already so small, her movement shouldn't have been restricted. Like, I guess they look at it as like the bigger the baby is, the more like the less room they have. And so they're just not inclined to move as much. I mean, they're moving, but it's not the same. But that was not the case with Cheyenne because she was small. And so that it was a complicated birth. I just want to say that I don't get like a go directly to go pass because I already had one, but it was a factor that I was able to carry
itself, but because of the male cells or the partner, in my case, donor, the body might be having a reaction to it. And he said, basically, it's like an overactive immune system. Like my body's trying to compensate for defending itself, right? For being attacked is what it's perceived as, like an attack. And so it's defending itself. He said it's kind of good, but I was like, except in this instance, right? But you'll see. And then the other one, same thing. He said that it's basically like an active immune system. Like my immune system is being really diligent, which is one of the reasons why the IVIG didn't get approved. That would be for someone who has an autoimmune disease. Like if someone had lupus, they would be approved for that IVIG. However, in their practice, and there are some studies, but the studies are not definitive enough for it to have passed the peer-to-peer review that he had to do. But in some studies, it shows that it's beneficial. So it's one of those things of like might hurt, might help, might help, can't hurt. And the logic is it's treating my body as if I'm having an autoimmune reaction to the fetus, right? So that's kind of what that is. And then the other ones, I just want to look really fast. HLA. And I also had another video that I did with Dr. Thornton, who's my actual RI. So I'll review that too. If it makes sense, I'll throw clips in of both of them because we covered, some of the things were the same, some of them were different. Sometimes one of them explained it better than the other. So I'll cut it together nicely for you guys so it makes sense. So my anti-HY immunity. Healthy women pregnant with a boy may generate an immune response against HY antigens. Male-specific minor histocompatibility antigen. Women with a firstborn boy and carrying HY restricting HLA alleles have significantly reduced chances for a subsequent live birth. As we know, I haven't given birth to a boy. So this patient, me, is at medium risk for triggering the development of anti-HY responses. The patient may discuss her results. So basically, because I'm at medium risk and because I've had multiple losses, they want to aggressively combat this, right? Because we want this next transfer to be that take-home baby. Lord Jesus, name it and claim it. Amen.
Amen.
So what are the puppies doing? I can hear them. They're like, Mom, why are you panting? So anti-HLA, AB, teeter, titer, I don't know. There's some pictures. I have no idea what these pictures mean. I guess because, you know, they charge you like $2,000 for this report. They want to make it look pretty. They did a chromosome analysis. I have 2 X's, so I'm just a regular female, cisgender. Homocysteine. DNA looks good. DNA factor.
I will say the frustrating part about that report is it's not consistent. Like the graphs are not consistent. So you could be low, but the way it's demonstrated is high. So it's like you really have to sit down and focus and read this report. I wish it was a little simpler. Like, because I feel like at my job, if we make a graph, it's to make it that all the data makes sense, right? It's not like you have to refer to 10, 9, 20 things. Part of it, I think they want you have to talk to the doctor and have to have it interpreted, no matter like how many times you've read it and what your reading comprehension is. I just wish it was a little more straightforward. Hi, Sarah. Are you going to bed? Where are you? Amen. Absolutely. Good to see you, 2K. Or good to be seen and good to know you're here because I can't actually see you, but you know what I mean. So Kitty, your first was a boy. So in this instance, I would say, we're going to talk about that on the other side, but I would say that would be one of the pros of knowing the sex or the gender of your child. Because if you had an indicator for that on your test, that if you're pregnant with a boy, your body is more likely to respond in X way and they combat that with medication, that would be a win for testing. But y'all know, I'm not a fan of it for myself. Not judging anybody who it makes sense for, but I think it's a case-by-case basis with the testing and not just for everybody, like a blanket for everybody. Also, can we talk about how cute my boobs look? I put boob tape on there. I have a bra on, but I put boob tape on there so they wouldn't crash together in the middle.
2 they tested me for, and PA1, 4G, 5G polymorphism. Morphism. Oh my God, I'm making a morphism. 5G allele on top and on bottom. What you need to know. The main function of plasminogen activator inhibitor type 1 parentheses PA1 PAI-1 is to decrease fibrinolysis, process that prevents blood clot formation. This test aims to determine if you carry a specific allele that may increase PA1 activity, thus increasing your risk for blood clot and miscarriage. So I am a low risk for that, but they are treating me as if I am not. And so that's why I have the Lovenox, because that's going to thin my blood. It's supposed to help. And he clarified I'm not meant to take the 81 milligram of aspirin, the low dose, until I start my estradiol. So one less pill, but he made up for it with some other pills. The girls are fighting over a toy right now. Please don't knock that camera down. Girl, listen here. Look at here. Look at here. Okay. I'm not going to go through this whole report because we did the report on a live, so it is out there, but I just want to give a context for what I'm about to say and so it makes sense when you hear what the doctor said to me, and so it's all in one place. But HLA, autoimmune disease, predisposition, so that's the medium, but we're treating it as high. Human leukocyte antigen genes are a cluster of genes involved in initiating an immune response. Some HLA alleles, haplotypes, group of genes, are associated with a predisposition to the development of various autoimmune conditions that can negatively impact your fertility. This test assesses your HLA system, which is crucial to determine key mechanisms that may impact your fertility. That's a typo, but you guys understand. So, and it says read more on page 49, but is there a page 49? No, it must be in the supplemental because this stops at page 35. Let me flip through. I should have earmarked these. Sorry, guys. Antiphospholipid antibodies. So instead of taking the, I wasn't going to do phospholipids. We were going to do the IVIG. But so I'm at medium risk. But again, the hydroxychloroquine will address that. Anti-nuclear antibodies, lower risk. This is lower risk. Thyroid is lower. So my thyroid, and this is interesting because normally on the labs you get one thyroid number or two. This has like multiples. I don't know if you guys can see that. But I'm all on the lower end for all of them. So the range, let me just see. There's antithyroglobin. So this thyroid test was much more extensive than the regular thyroid test that I have been taking as part of the process. So there was like 5 different values for it, which I thought was interesting. Luckily, I'm all within range for all of them, but that one was, I don't know, it kind of threw me for a loop there. globulin antibody, thyroid peroxidase. I should call my sister, she knows these things. TSH, which is what I always think of as, so my TSH is 1.16, measured by UG/DL. My TSH receptor antibody is negative 1.10. Or less than 1.10. That must be the bottom of the test. So it's lower than what the threshold of the test is. Total T4 is 7.6. Total T3 is 131. And then I didn't give you guys the number for the top. The anti-thyroglobulin antibody is less than 1. No. Thyroid peroxidase antibody is less. Give me 1 second, guys. I'm going to cut this. I'll be right back. After these messages, we'll be right back. They're in the room, but they're still going. So if you have dogs, I'm very sorry. I'm sure they're going crazy. In the meantime, while I got up, I did get the supplemental, so we can do this reference, hopefully really fast. So we said HLA autoimmune. Oh my God, I feel like a bad mom. I had to take their toy away, but at least they're quiet until they find another toy. Okay, so here's the additional reading. HLA mismatches, physiology, human leukocyte antigen genes, commonly referred to as the major histocompatibility complex, MHC, say that 3 times fast, genes, are a cluster of genes present on the chromosome 6 and are involved in antigen presentation to T cells to initiate an immune response. Oh, interesting. Okay. In most cases, this immune reaction leads to the destruction of cells displaying non-self peptides. So you guys know it's a miracle that we can carry babies, right? It's a miracle that our bodies don't just naturally attack it because it is a foreign object. Even your cells are not, it is a foreign object. I know I said it's less likely to attack mine, but it's not unlikely that it attacks my own cells, right? Because it's like, what are you? Why are you here? You don't belong here. I have to protect the human. HLA molecules play a key role in organ transplantation and are associated with many diseases, including autoimmune disorders. While a mismatch in human leukocyte antigens between a donor and a recipient in organ transplantation may lead to a graft rejection, most often due to the formation of antibodies, a certain level of difference between the mother's and father's HLA alleles inherited by the embryo and defined as a mismatch is necessary to actively generate immune tolerance of the embryo. Thus, couples with significant matched alleles for HLA genes. Oh, wait, here we go. I have this random thought, and you guys actually put this idea in my head because I'm an O type. I'm not an O negative, I'm O. But I know someone in one of our other lives. Also, if you guys want to come up at the end of the video and you want to talk, put your makeup on, put your wig on. We'll pull you up. But the thing is, with the O, like I'm a universal donor, right? And you guys, most of you know, if you've been here for a minute, I donated a kidney to my sister. Like O is a universal donor. Is it being like a universal donor, I wonder if my body has an aggressive immune system because it's like warding off things. It just feels like my immune system is a little bit too aggressive for these transfers. So we're trying to calm it down. We're trying to get rid of inflammation. And we're trying to get my omega-3s up. So just a random, obviously unofficial poll, like how many of you guys who have had repeated miscarriages are O or O negative blood type? I'm just curious as to like what the real impact of that is or implication. It's maybe more prone to infertility, repeated implantation failure, and recurrent pregnancy loss. So that is a good point. I mean, hopefully you understood that, but it just reminded me because some of you guys are like, oh, what do I get tested? If you are not doing single mother by choice, if you are doing, you're in a heterosexual relationship, you want to get your partner tested too, because you want to make sure you guys are compatible. And also like with me, I mean, obviously I'm not using my own eggs, but I am a carrier for sickle cell. So when I was of, making baby age, my partner had to be tested to not also be a carrier of sickle cell anemia, because then the child would have sickle cell anemia. So that's just one example. There are lots of others, but you want to make sure you're both compatible. So you might as well go through your fertility testing at the same time. And that was the thing of like getting a match sheet for my donors, also because you just want to make sure there's not an incompatibility issue. So let's see, what is this one? Anti-HY immunity, which I'm also going to be treated for in this next FET. Physiology. During a first pregnancy with a male fetus, we read that. Although present in 30% of women, anti-HY antibodies have been linked to a secondary recurrent miscarriage and subsequent pregnancy or other pregnancy complications such as stillbirth, placental abruption, or fetal growth retardation, which I don't think they say retardation anymore because Cheyenne had intrauterine, it used to be called, it's IUG, or intrauterine growth retardation. That was the old name. I think it's now restriction. Anyway, because retardation is not PC anymore, right? That we don't say that. Anyway, all these events being the result of an inflammatory environment. So I wonder if I was having boys. I wonder if Applejack was a boy. For those of you who are new, Applejack is the baby that I lost from my very first IVF with my own eggs, where I had the miscarriage, which was crazy because that was like my second miscarriage in about an 18-month period, maybe a little longer, but close to that. Okay, what else do we want to go over? What notes did he go over with me? HLA, anti-HLA. I do like that they give you the supplemental reading. It's not as pretty. I'm telling you, this is where the $2,000 went. You heard? Okay. So Pregmune clinical data. In our practice, a retrospective analysis based on 828 patients have shown that miscarriage rate is significantly increased in patient with at least one HY restricting allele and undergoing an embryo transfer. Oh, wow, with at least one. So that is, and then they give you a nice little graph. Absence of HY restricting and presence of HY restricting. So that red are the losses. Or I'm sorry, they're both the losses. The red is the number of losses with presence of HY, and the blue is the number of losses or the percentage of losses with the absence of the HY. So it's not a guarantee by taking these meds, but obviously it reduces the chances based on their study. Granted, it's a small study, 828, but honey, I'll take it. I'll take it. Pregmune is a test that is created, which one of you guys actually told me, it's created by Braverman. So they're using their own, it's not cohorts, right? Because they're patients. They're using their own patients as part of their studies and using that to compile this data and develop these standards, or they're saying these are what their standards are based off of, and here's the data to support it. Okay, embryo MTHFR, I don't have that. So that's, where your body cannot process folic acid, which is a synthetic form of folate. So they tell you to take folate. I take folate anyway, because why make my body process the synthetic? I know, I still drink Diet Coke. I know that's synthetic. I'm working on it. Stop judging me. Okay. I think that is all I want to cover. Just let me double check. And the test for if your body can process folic acid is relatively inexpensive, and your OB/GYN can do that, or your insulin
RE.
resistance and PCOS assessment, homocysteine minus 7.8, hemoglobin, goblin? No, I'm kidding. Minus 5.3. So that's definitely something you want to get checked too. If you're like, where do I start with my fertility test? Definitely get your insulin checked. Vitamin D. We said thyroid already. Prolactin, that is not in here. So what is my protocol based on those results? I'm glad you asked. This is just my RI protocol, not to be confused with the FET protocol that's coming from the RE, the reproductive endocrinologist. This is the reproductive immunologist. We'll marry them up, and I'll be taking all that. But once we get into that cycle, once that period starts and we have day 3, I'll go over that with you guys. So here's what the protocol is. They give me a timeline, and then it just says, when you are ready to start, keep me posted. I will guide you with the meds and testing. So I will need repeat immune testing, a shortened panel with my first beta, whether it's positive or negative, as it will provide us with information on how your immune system is responding to the embryo and will let us know if we have to make any changes to your immune protocol for your pregnancy or subsequent cycle. Let us know your beta date and we will order the testing. So start fish oil as per your Pregmune report. So this I clarify with him. It starts with 6 grams, which if you saw the other video, you know I'm not taking enough in. 6 grams, which is 6 pills. Each pill is a gram for 2 weeks, then 4 grams for 2 weeks, and finally 3 grams as a maintenance dose, right? Because my fatty acids were very low. The IVIG gave me next C, so I'm not taking that. Instead, I'm taking the hydroxychloroquine. But let me just read it in case you are prescribed it, just so you have the background on it. So it would be start IVIG 10 grams. First dose should be a week prior to transfer and continue every 2 weeks. For our indication, since we are using IVIG off-label, it's typically not covered by insurance. We work with various pharmacies that dispense the medication and will set up a nurse to come to your home to do the infusion. Cost of IVIG has been running around $120 to $150 per gram. This is just an estimate, and they wanted me to do 10 grams, right? So about $1,000 if we just do the mid-range of like 100 per gram. So about $1,000 per infusion. Once we send in the script to the pharmacy, they can give you exact pricing. The pharmacy will attempt to get the nursing services provided. So if I had been covered for it, the nursing would have been covered. I should find out. Like maybe I do. No, because that's just money. Let's keep it cost low. But my insurance would pay for a nurse to come and administer the IVIG via IV. Say that 3 times fast. So yeah, an estimate per infusion, if not covered by insurance, is about $2,200. Most patients are on IVIG throughout the first trimester, but pending repeat immune testing, the doctor may recommend continuing longer. If you decide not to use it, Dr. Thornton advised you may consider using Plaquenil. So that's the route that I went. Lovenox. So I'm going to start Lovenox 40 milligrams subcutaneously daily in AM with estrogen start. Injection is giving subcu in the abdomen to the side of the navel or below. So
this one I'm a little afraid of because I posted the Lovenox on IG and asked like how people did with this, and everybody was like, I bruised up. I mean, it makes sense because it's thinning your blood, but it's just like, oh my God, how tender is my belly gonna be? Because I feel like the P4 shots, the progesterone in the butt, I got used to, and I had like a nice system going, but I don't think I can just keep putting heat on my belly area. So hopefully it doesn't look crazy. If anybody has any tips and tricks on Lovenox and not tearing up my abdomen, please share.
I was like, there was some other medicine I had to take sub-Q. What was it? Oh my God, I can see it, but I can't.
I think it was Avidril, the one
It was already pre-mixed. Anyway, I took it when I was doing my, I got to do it live in a second. When I was doing my stimulating my follicles for egg retrieval. So expect some bruising and burning at the injection site. 1 week after starting Lovenox, you will need a heparin anti-XA level. This blood test is done 4 hours after your morning dose. It can be done of Lovenox. It can be done at your local LabCorp, no fasting. We'll email you a script. Then prednisone. Start prednisone 10 milligrams by mouth twice daily for a total of 20 milligrams daily with estrogen. Best to take with food. So estrogen, prednisone, and the Lovenox will be all at the same time. Plaquenil I've already started ahead of time. And the omegas I've already started ahead of time. So you will continue the same dosage until further instructions. We wean off prednisone if the pregnancy test is negative or at 12 to 4 weeks of pregnancy on a case-by-case. I'm sorry, 12 to 14 weeks on a case-by-case basis. And then the consent, I had to sign a form saying that I understood that prednisone in early pregnancy has an increased chance of a cleft lip. So I had to sign that. And then calcium, we recommend starting calcium 1,200 milligrams daily with the estrogen, and then baby aspirin with the estrogen. With the positive pregnancy test, you will continue all immune therapies. Based on repeat immune tests, we will provide you with instructions on when to stop, taper the medications based on your result. If the pregnancy test is negative, we will provide you with instructions to stop, taper the immune. So that's it. That is my protocol. We are on the good foot, y'all. So stay tuned for the call with the doctor. Junction, what's your function? I am waiting on Dr. Vidali to call me. Hello, how are you?
How are you?
I'm well, thank you. Nice to meet you.
What a nice setup you have there.
Oh, thank you. I'm just working from home today.
You have a beautiful color in your walls. Looks great.
Thank you. Thank you.
Looks great. Looks great.
Awesome. So this is our first time meeting. Is everything okay with Dr. Thornton?
Yes, I've seen your testing.
Okay, so I'm just going to give you guys this. I'm not going to say too much, but I do want to know your opinion about this. I had never spoken with this doctor before. I'd always talked to Dr. Thornton, and then they sent me the email because I was like, hey guys, I'm still waiting on the results from my ultrasound. Like, am I cleared or not? And then they scheduled me with Dr. Vidali, and I sent a note like, is everything okay with Dr. Thornton? And they never responded. So I'm thinking like maybe he left this practice because I think one of you guys reached out to me. It might have been a couple of you ladies actually who reached out to me. Like he used to be in Connecticut, or you thought he was the one in Connecticut. So, and I know he also used to be at Columbia. So I'm like, did my doctor leave? But then as we got into it, I realized he was talking to me because he's like the head dude in charge, right? And I had voiced a complaint to that nurse who was nice, nasty. And I just told her that she was the most unprofessional person that I've ever had to interact with. And so I feel like part of this was like cleanup. He never wanted to actually blame her. He kind of, in my opinion, he mansplained it. But you guys let me know what you think about once we get into that part. I was just like, why are you calling me, sir?
In your images so far.
Okay.
So, and unfortunately, you've been through a lot, right? Because you've had, unfortunately, 3 miscarriages and 5 failed IVF transfers. That's a lot.
Yes.
You did have 1 live birth. Is that correct?
Yes, a very long time ago.
Okay. And since then, you've been sort of like struggling to get through this.
Yes. Yeah. So I switched to donor eggs last year. So the very first IVF was with my own eggs, and that was the early miscarriage. And then last year I went to donor eggs, and I had...
With the assumption that it was going to work, right?
Yes. Everyone was like, oh, it's your eggs. There's something wrong with your eggs. We'll get you pregnant.
There's nothing more frustrating when people do the compromise to do IVF do egg donation, and then because it's going to work and then it doesn't work. It's extremely frustrating.
Yes, it is. And it's hard because you transition and it is like a loss, right? You're going to become a parent, but not in the way you intended. So there's already that grieving process. And so you think, well, this is what is going to get me my take home baby. And then when it doesn't work, it's just like,
Oh yeah, it's like a double the pain in a way. Yeah. I agree with you.
So this I found refreshing. This is the only like reproductive doctor that I've talked to who understood about the loss, like the loss that you have when you decide not to use your own eggs and you move over to donor eggs. Because especially like the very first, when I was at RMA, I just felt like she completely swept that under the carpet. Like, oh, just do donor eggs and then we're off and you'll be pregnant. But there is like a mental process that you have to go through. And I did like, especially this is my first time meeting him, that he showed empathy, right? Like, and he's a male doctor. Like, so I was just impressed. I thought that was
particularly traumatic, I would say. Nevertheless, here we are.
Exactly.
And you're at Columbia still, right? You're still with those guys at Columbia?
Yes, Dr. McConnell, yes.
Yeah. And, I work with a lot, I used to be at Columbia, myself as well as Dr. Thornton, whom you've met, talked to. And we both, used to be there. So we're both products of Columbia.
Oh, nice. Did you work with Dr. McConnell? Was she there when you were there?
No,
she
was before my time. And she may have been there when, because actually Dr. Thornton was a professor at Columbia for many years. He was running their egg donation program. So everybody knows him there. He's very much involved there, I think. He's such a nice guy.
Dr. McConnell speaks very highly of him. So they work together. Yeah.
He's a good guy. So a couple of things. First of all, I'd like to go, I know you've, discussed it with Melvin already, but, a couple of comments about the report immunological testing, right? Because sometimes it can be confusing. People don't understand it. The doctors.
And he's kind of badass. I dig the tats on his arms. Like, I don't know. I just liked his vibe. Yeah, it was refreshing. He was refreshing.
Sometimes don't understand it, but there are some findings in your report that, that do encourage us to, recommend some treatments, right? Like the borderline antiphospholipid antibodies. Do you know what those are? Those are like seen in people who have autoimmune problems.
Right.
And I know values are borderline, which means like a little bit higher than normal, but not really very elevated. But that, the reason why we are concerned about those is because sometimes people, when they do get pregnant, those values that were borderline, they become elevated. So we don't like to.
Laura, this is such a good point. Laura says, I get so tired with the, at least you can get pregnant. That's a good sign to just keep trying and just bypass the feelings and emotional battle and all of this. Right. And every time you do get pregnant, what that anxiety level is like, right? Like I feel like they should at least, acknowledge that bit of it, because after you've had a miscarriage, you're always thinking then what's going to happen the next time. It's just like human nature. You try not to, but you already know what your past is. So, and I hate when any doctor says at least. Any human being. I just feel like we should not be shooting for the lowest common denominator, which is exactly what at least is. So yeah, I just think it's important for them to acknowledge it. And I was like very excited that, well, not excited, but I was more jazzed to talk to him, because I think you can tell I was a little bit like, where's Dr. Thornton? But he just was like very relatable, very empathetic and compassionate.
Right.
And the second part of it, you had some, we call those matching. It's histocompatibility, which means that between people, and there are certain findings between the partners that increase the chance of a miscarriage or an implantation failures. And you have one of those findings. Okay. And they lie into, to go a little bit more into detail, they lie between the certain receptors that are present on the baby, basically, and then on the placenta that affect the way the placenta and the baby overall interact with the place where the placenta implants, which is called the decidua, the uterus, basically.
Okay.
And there are some configurations of these genes which are called the HLA genes that increase the chance of a pregnancy loss.
Okay.
And you have that.
Gotcha. And that's
the third
true.
thing that.
Sorry, is that true irrespective of the baby not being genetically? It's just how it's the receptivity. It's a receptivity issue?
It deals with the DNA of your partner, of your husband.
Okay. I'm double donor, so I'm using the donor sperm, donor egg.
Oh, you're using that. So correct. Let me correct that. It deals with your ability to have that. We don't know their part, okay? But we know that your part is a higher risk.
Okay.
So it could be that they're low risk or that they are no risk, but you have that propensity. Let's put it that way.
Okay. So we're going to treat that to reduce that risk.
Correct. Okay. But it's an unknown risk, if you will.
Okay.
And then And then the last part is that you do have some anti-HLA antibodies, which are a sign of like a relatively active immune system.
Okay.
They can happen, anti-HLA antibodies, by giving birth. But you said that you gave birth a very long time ago, so they should be negative by now.
Okay.
So overall, that's the reason why we recommended, managing this. And honestly, if you hadn't had the losses, I would be
I'll go back a little bit. I just want to say this really fast. I also wondered if, when he said that, if you had had the birth, does like the miscarriage, does your body physically think of that as a birth? Like, I feel like especially the one that I had in 2017, like I could feel my cervix opening up. You know what I mean? Like, is that triggering everything? Obviously there's not a full placenta, but I just thought about that like while I was listening to him. I wonder if each miscarriage leaves some sort of remnant behind. I mean, I haven't had one in over a year now, because what was it? April of last year? It was either April or May. I think it was April. So it's been over a year, but I wonder. I see that some of the questions, B Black and a couple of others, I've starred them once this is done because I want to actually talk in depth about them. And Jennifer, if you want to come up and get input, I'll drop the link in once we finish the watch party. Because I feel like the collective, even if I don't have the answer, the collective will have at least some situational commentary, right? So yeah, I just wanted to acknowledge that really fast. And I did rewind it a little bit here.
HLA antibodies, which are a sign of like a relatively active immune system.
Okay.
They can happen, anti-HLA antibodies, by giving birth. But you said that you gave birth a very long time ago, so they should be negative by now.
Okay.
So overall, that's the reason why we recommended, managing this. And honestly, if you hadn't had the losses, I would be less aggressive, right? Like the decision to manage a little bit more aggressively comes not just from the immunological finding, but also from the history, right?
Okay.
You got to put those together, right? So one doesn't. If somebody came to me and with your labs and didn't have any history of losses, one would be an NIVF failures. One wouldn't be as aggressive, but because of your history, that's what happens.
Okay.
And the last thing is this approval for the IVIG, which I know was a very unpleasant experience for you. But, the reality is that, these insurance companies, like, as you know, they are jerks a lot of the times. They don't want to pay for anything, but they also tell people, oh, but if you change that, it works. It doesn't really work that way. You can't lie on it's almost like somebody saying, do insurance company covers breast augmentation? Well, they do in the context, let's say, of breast cancer. But if it's for aesthetic reason, then they don't cover it. And the doctor cannot do a procedure for aesthetic reason, and then lie and say it's for breast cancer. So
I just want to clarify. I do want to clarify. Nobody asked me to lie, nor did I ask anybody to lie. I just want to clarify that.
No, I'm not saying.
Okay.
I'm not saying. Hold on. Yes, sorry about that.
No worries.
So of course you didn't. I
Okay.
mean, I know that, but sometimes they will say, "Oh, just change the diagnosis." But the diagnosis is what it is. You understand that? So,
nobody asked to change the diagnosis. I just want to say that because I did have a tense conversation with the nurse where I asked her about idiopathic. Nobody asked me to ask about that, and then she went into accusing me of thinking of a fraud.
No.
Okay.
No. I think it was more like maybe she told you, like, look, we don't change the diagnosis because it is what it is. But, in any case,
no,
it's just a communication issue with these people.
So this is what I want to say for the record. That is not what she said. And this part peeved me a little bit because I felt like he should have listened to my side of the story, right? Or at least my context for me, because if he's just looking like after I send her this, and this is the thing, I cannot call this nurse. I cannot call her. Only she can call me, and she calls from a block number. I don't know if that's because she's working from home and they don't give her a company phone. I don't know what it is, but it comes up as a block number. And I only can leave a message for her at the office, which I don't think she is, and wait for her to call me back, or we only can talk via email. So I had finally had enough, and I just told her, this is very unprofessional. You are the most unprofessional person that I've ever had to work with. I can't call you. You call from a blocked number. Then if you call me and it's a missed call, you are immediately sending me an email accusing me of not being available. Like, you are at a business, whether you're from home or not, you are at a business. You should keep business hours where you answer a phone, or at least there's a voicemail that goes directly to you. And I asked her, can they mark it as idiopathic on my form? Because she didn't tell me what the diagnosis was. So I was like, I'm left to think there is not. So idiopathic means there's no known cause, right? I know that from my sister's kidney failure. It was idiopathic. So for her to, so then when I told her she was unprofessional, then she came back and was like, well, we can't falsify documents and we're not going to commit insurance fraud. And I was like, whoa, I didn't ask anybody to commit fraud. I didn't ask anybody to lie. My question was, can it be idiopathic? All you simply had to do is say, no, you have a diagnosis and here is the diagnosis. So it got blown into this whole big thing and like, oh, well, we can't commit fraud. Why would I want to fraud my own insurance company? Why would I want to commit fraud against that? My insurance is paid by my employer, so I could potentially lose my job. Like, there's no reason for me to lose my job because I'm trying to get free IVIG. So I just thought it was like very strange. I also am not liking how he's mischaracterizing the insurance company. I've never had a problem with these insurance people. Like, yes, there might be some paperwork you have to fill out. Who doesn't do that with, but I've never felt like the insurance company was shady or trying to get away with something. And I just feel like their approach is, and maybe because, you know, they deal with a whole bunch of different insurances, I don't know, but I work for a Fortune 50 company. Like, the insurance is legit. You know what I mean? They're not like, and insurance is determined by my employer. So even though the insurance company might initially say no, they were supposed to do a peer-to-peer. It ultimately would go back to my employer. Either they would cover it under those circumstances or not. So I just don't like the way he's characterizing it. Like, insurance is bad. They're playing with you. Trust us. Trust this nurse, even though she's been gaslighting you, basically, like accusing you of trying to commit fraud. Like, why did fraud come into our conversation? Why did a lie? Just like how he started with, oh, if there's a lie. So that's a strong word. That's why I wanted to clarify. I've not lied. I've not asked anybody to lie. Nobody from the insurance company asked me to lie. Like, let's get that off the table. So this part was like a little touchy, but I think in rewatching it, he just doesn't like confrontation. And I can see that I was chomping at the bit. Like, I might have went off a little bit, but he just wanted to squash it and move on, which at the end of the day is fine because the conversation wasn't going to change anything. I just don't like the being under a shroud of questionability. Like, I'm not trying to game the insurance. If they were going to pay for it, they were going to pay for it. My thing was, let's ask them, because she was initially refusing, saying, they always deny. Everybody gets denied, so we don't even do appeal. So then that's when I was like, that doesn't make any sense because I'm not the same as the other patients. We don't, even if we have the same insurance company, we don't have the same employer. So we have different coverage, right? So that was like, I don't know. That was the only part, but he did have compassion. So this is more like businessy side. So some doctors don't like to deal with the business side. I mean, that's why you go through someone else to talk about your finance and all that. Like, they want to be care providers, but I think he was giving her grace. He was giving me grace. He was like, I wasn't there. I don't know, but I don't like the way that he's characterizing the insurance company.
Which is always annoying, but, you know, we always try and unfortunately, you know, we've not been lucky in general because it's outside of the realm of what they cover. Unfortunately, you know what I'm saying? It's outside of the realm of what they cover. One of the things that we usually do if IVIG is not covered, we use, instead of IVIG, we use this drug called
the Plaquenil. I have that. The Hydra. Yeah. Yes, I have it.
Yeah. Which is, you know, there are studies that use one as an alternative to the other with success. You know what I'm saying? The reason why the report says
I think
IVIG
so too.
is because that's like the standard, especially in Europe. In the US, is used less frequently, but most of the stuff have been done with IVIG. So, you know, because the report has to present the standard, you know, like the gold standard. but that doesn't mean that you're necessarily shortchanged if you use the Plaquenil or the Neupogen instead. Yeah, I just want you.
So does that mean in the peer-to-peer they still declined it after further explanation?
They don't. Yeah, correct. They don't want to, deal with it. Mostly because it's already it's already used as a.
I think you are right that he wanted to buy. Again, I think he just doesn't like confrontation, and he perceived it and I might have gotten nutty. I'm trying to be a better person, but I'm not always. And the thing is, I just feel like it could have been handled differently all the way around. But even he's not saying outright, he never said the peer-to-peer failed, right? So I'm asking him specifically about the peer-to-peer, and I don't feel like he answers it specifically. I mean, I could go back on my insurance side and say, did you do a peer-to-peer? I want to see the outcome of it, the notes. But it is what it is. I already started taking the Plaquenil. I started taking it on the 1st because I was naming it and claiming it. But I just don't like the tap dancing around the question. Just answer it and deal with whatever it is. You know what I mean? So, but again, it was my first time meeting him. But I feel like if that would have been Dr. Thornton, he would have listened to me. The same with Dr. McConnell. I think especially too as a woman of color, people tend to be more dismissive of us. And so obviously McConnell is less likely because she's a woman of color. She's also a Black woman to be dismissive of me. But in general, I feel like dynamics, irrespective of color, it's a male doctor and it's a female patient. I always feel like the male doctors, and the same with Dr. O, I loved him to death, but he was the machismo. But y'all know I have daddy issues. I already said I like this man's tattoos. So, but the whole okay, little lady, let me explain it to you, where I don't feel like now we're partnered. You're putting me below you in a way. Just because you have more information on this topic than I do doesn't mean that you're above me, if that makes sense. So I just was like, but you can see it on my face. Let me get it back over here so you can see. Look at that. I was like,
IVIG is mostly used off-label.
Okay.
So you're already off-label and out of their indications, basically. Okay. So that's how they do it. So
even that is an oversimplified answer, because when I was doing IUI, I did Femera or Letrozole, which we all know is off-label for fertility. The insurance company paid for it. So this is where we get into trouble, where we try to give anecdotes that don't always apply. They didn't deny it solely because it was off-label. There were other things to it, but I feel like if he would have had a peer-to-peer, or maybe he wasn't the one who attended it, maybe it was Dr. Thornton and he's talking to me because he wanted to do cleanup, I would have liked to hear specifics about what they said, what was the reasoning for this not being, why we couldn't make an exception. But at the end of the day, it doesn't matter. I'm being super nitpicky, but I've paid a lot of money and I've also put a lot of tears, blood, sweat, and tears into it. So I just feel like those are simple enough things to answer. Do you know what I mean? Make it make sense. That's all. I'm not saying that you're lying. That is not what I'm saying, but I am saying explain it to me where it makes sense, and not just, because you're off label, because we already know that to not be true just from the Femera part of, and I know there's a vast expense difference, but if that was the insurance's policy, cut and dry, or if it was my employer's policy that the insurance company was effectuating, then I would have never gotten approved for Femera, because that's off label. It's not for fertility. Anyway, y'all let me know.
And that's really where it's at with that. It's just honestly, IVIG is the kind of thing that gets really approved only if people have a full-blown autoimmune condition, let's say lupus.
Okay.
They also don't regard the current evidence in the use of IVIG for recurrent pregnancy loss as strong enough. They're like, well, it's still early. There's not enough research, blah, 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 blah. So that's another reason why they won't let it give it.
Understood. Are there studies that have conclusively shown improvement, or no? Is it experimental?
There are, but there are randomized prospective studies that have. But not enough, I guess, but the societies that are responsible for determining the guidelines, like the American Society for Reproductive Medicine or the European Society for Reproduction, they, in their guidelines, they're like, yeah, we understand that these drugs are being used, but more studies need to be done. So they don't, for these guys, which are committees made of doctors, to actually say, all right, this is what we recommend for everybody, they need a lot more stronger evidence for that. And we may never have that evidence, certainly not in a short time, because not a lot of research is going on in this area, and so not a lot of money is dedicated to this field. There's no money in it anyway. So it's one of those areas where the progress is not being made that quickly. You understand that? So that's the other reason. So when they go look at the guidelines, and the guidelines say need more studies, then you're stuck with that, right?
Okay.
So that was, I think, the most straightforward answer, right? Like, that is a legitimate reason for an insurance company if there's not enough documentation, which is why a lot of even the stuff that they are going to do, Braverman, Columbia wouldn't do, because the studies were not conclusive enough, right? So you could have, what you want is a preponderance of the evidence, right? You want the studies that you do have to demonstrate that it's more likely than not to help, especially at that expense, right? Because we were talking about $2,000 per infusion, and I would be having them every 2 weeks. So for that amount of money, and honestly, for my own like physical investment, to sit there and go through that, you want it to be 51% in favor of it working versus it not working, and not somewhere in the middle. And I think there's just so many variances of it. But if you go to someplace like CNY, they throw everything but the kitchen sink, whether you need it or not, right? I think they do intralipids for a lot of people, but it's sort of one of those things. So this was that, I think when he said that backed me off of it. Okay, like there's not enough. And I did not do any research on the IVIG after they told me, so I don't know what the studies are showing. But it's the same like with DHEA, like some clinics will use it and some people are like, it's not enough. But like, who is it? CHR here, Center for Human Reproduction in New York. They use it on a regular basis. So anyway, when he said that, then I was like, okay, I'll swallow that pill. But the other stuff, I was not buying.
Yep. So it's just like the way it is, with the way these companies approve stuff, and that's why we're not lucky in approving these medications. Almost never.
Okay. I mean, as long as the effort was made, that's all I ask. As long as an effort was made, yeah, because you don't know until they answer you specifically, right? You can't make a general thing of like, they never do it, because each patient is individual, right?
Oh, no, I understand that. I agree with you. Now, the other thing is that the ultrasound that you had, overall, the uterus is of normal size. I think there is a little bit of adenomyosis in the uterus, which is adenomyosis is like endometriosis, but in the uterus instead of like in the pelvis.
So I am so tired of being told about this adenomyosis. Now, you remember when I had my last FET, the doctor was saying that. And then my very first RE over RMA said it looks like I have it. The only way you can conclusively diagnose that is with a biopsy. And nobody has found it in a biopsy. I had how many? Like one at the end of last year. I had 3, right? Because I had to do 3 rounds of those meds. So I don't know what is it on my scans that look like this adenomyosis, but he's now the 3rd person who said it, but it's not coming up on a test. So I was just like, oh, not another one. And then I asked him, don't you have to have a biopsy? And then he's like, oh, I'm not going to do that. And I'm like, okay, so then I don't have it.
Pelvis.
Okay.
But for somebody like you who's had multiple instrumentations of the uterus for pregnancies, and I don't know if you're, so I don't know if you have any symptoms. Do you have any pain or cramping or anything like that? But, you never had really any of that. So overall, I would say that it's not something that makes me want to say, hey, we need to do any intervention or surgery or anything like that, you know?
Okay.
To look for endometriosis or anything else.
You would need a biopsy, right?
I don't think it's necessary. I mean, visually, I think that's what it is. And as long as you've had a hysteroscopy that showed that the cavity was normal, which I'm sure that the docs at Columbia did.
Yes.
Because that's part of their protocol, I think you're okay with that. So my recommendation is to move forward with the Plaquenil, a low dose of prednisone, and the blood thinner, and then we're fine like that.
Okay. Is it the Lovenox is the blood thinner?
Right.
Okay.
Same, Laura. That is, and I confirm that with, if you go back and watch my one video with Dr. McConnell, I was like, I've always been of the impression that there's a biopsy required. That is not something you can see visually. And she was like, you're absolutely right. So he's saying it looks like it, and then I was like, well, maybe it's scar tissue. But remember when I had the first procedure after my fourth frozen embryo transfer, they did a biopsy, and then they also did what I couldn't think of a name for, filing, because they saw some scar tissue and a dent. So they evened that out. But they were in there and they biopsied me, and there was no sign of endometriosis or adenomyosis. And I've never had a painful period in my life. Like, I don't even have cramps. I'll have a little bit of a backache. My flow is normal. The timing of it is normal. So like, there's no supporting facts or factors that would indicate that I have it. But again, he's the third doctor to say that he's seen it. But it's misleading when they say that it looks like it, because it only is diagnosed with a biopsy. Like, now you could see it and that could cause you to want to get a biopsy, but I've had 3 since the other doctor said he saw it during my fourth transfer. Now, he also said he saw a fibroid, which that ended up being right. There's like a 2 by 2 by less than 2 fibroid, which I did not have going into this. So I'm going to claim it's the hormones that they've given me, the synthetic hormones, till the day I die. But yeah, it's interesting. But overall, I like him. I'm super nitpicky. I've been at this a while.
So I will go forward with that plan. The only sort of caveat is that you have to be on the Plaquenil for, a few weeks before you start the embryo transfer.
Right. I started it July 1st, and the plan is to transfer in August. Okay.
Yeah, perfect.
I do have a question about the omegas, because the directions say like 2 milligrams and increase it, but the over the counter that was recommended to me is like 2,100 milligrams. So I'm not sure how to.
That's 2 grams.
That's 2 grams. Okay.
Yeah.
So then I would, if a dose is 2 pills, in order to increase it, I'd have to take 6 pills to start. Is that what you're saying? Every 2 pills is.
That would be 6 pills would be, no, wait a second. 3 pills would be 6 grams. That's it. That's all you need.
The dose is 2 pills is the 21. Let me get the bottle, because I just want to make sure that we understand.
Yeah, let's take a look. Yeah.
Because the recommendation is to start out higher and then taper it down.
Oh, I know, but you're starting at 6 grams, right? Can I see the bottle?
Yeah.
Yeah, so triple strength, right? So that's 2 grams.
So a serving size is 2 soft gels, right? So you're saying 2 soft gels is 2 grams.
That's 4 grams already, right?
No.
How much is one pill?
It doesn't have it by the pill. It has it by the serving size.
Okay, how much is a serving?
2 soft gels.
All right, then you take 3. Sorry, then you take 6.
Okay.
6 grams is the maximum daily dose.
And then taper it down, right?
Right, because 6 grams is a lot.
Okay.
You should be fine on 2 grams a day.
Okay.
Let me show you guys, because I was showing the camera on my laptop, so it missed it. But here is the pills, right? So I have to take 6. Oh, wait, these are empty. I dumped them all in here. I ordered another one. Let me just show you what one pill looks like. That is 1 pill. What do I have to compare it to? I don't know. If I show you, this is like a regular mouse pad. I don't know if that helps. It's pretty big, and he wants me to take 6 of these, which I don't think he was listening to me at the beginning, because I started off with 6, and then I think I made him a little nervous. He's sweet though.
After days.
After how many days?
After a couple of weeks, you should be fine.
Okay. Because let me just make sure. Oh, I printed it up. Yeah, okay, so 6 grams for 2 weeks, 4 grams for 2 weeks, and then 3 grams as a daily maintenance.
Exactly.
Okay, so start off with the 6 pills.
So it's 6 pills for 2 weeks. Then you go down to 4 pills for 2 weeks, and then you go down to 3 pills for 2 weeks. 6, 4, 3.
Okay. It would 3 would still be, oh my God.
3 grams. Each pill is 1 gram.
Understood. Okay, I see what you're saying.
1 pill, 1 gram.
One. Yes. Okay. Understood. Okay. Thank you.
Oh, good. My pleasure. Are you kidding me? Focus.
All right. I think I'm good then. Thank you, sir.
All right. This is. Let me give you my cell phone number in case you want to get in touch with me in there.
Okay.
Because you're in the middle of this. I don't want you to be confused or something. Just send me a quick text if there's anything. Okay?
Appreciate it. Thank you.
Make a mistake.
Thank you. I appreciate it.
It was a pleasure seeing you in person.
Yes. Take care. Thank
right.
you so much.
Okay,
It was a pleasure meeting you. Bye-bye.
Bye-bye.
Baby. Okay. So Dr. Thornton is still there. This was the cleanup because I had sent that nurse a heated note about how she was unprofessional because she was like, we don't commit fraud. And I was like, who asked you to commit fraud? Who asked you to lie? Anyway, we're all good. Hopefully they really did the peer-to-peer. I already started taking the plaque when I was just like, let me be prepared. So, all right, let me get back to work, girl. I'm excited. All right, pretty cool, right? So I think I'm in a good spot. If you have any questions about any of this, let me know down below. I'll talk to you later. Bye. Baby, that's to us all.
All right. Oh my goodness. Okay, there's lots of questions. I know somebody wanted to come up and ask. So I'm putting the link in if you want to come on camera, get your lip gloss, get your wig, but you see what I'm looking like. So it's all love in here. It's all the family. Davinia, I'm glad you made it. You're not super late. Kitty, you're going to CNY Clinic. Have you already started? Okay, so there's some of these that I starred that I want to go through because I want to make sure we touch on them. So Kitty, you said your first was a boy. I had my first when I was a teen and wasn't trying and told I couldn't have any children, so I didn't know about testing. Yeah. But didn't want to just go throw that out there. I was following that, but I wasn't sure which one you were thinking of. Michelle. Oh my God. Tanya. Wait, oh my God. Is today Wednesday? Happy hump day to ya. Happy hump day to ya. Happy hump day. You're O positive, CMV negative. Okay. Oh, is it if you're not negative, you're positive? I just always thought I was O. My mom is O negative. But I guess that makes sense. Or is it an O positive and an O negative? I'm so confused. Okay, Laura, this I wanted to see. So I think universal donors, O, can give to anyone, but can only receive O negative. So since you don't have any A or B antigens, it's a great question if that makes your immune system strong. I'm curious to know too. Yeah, I wonder about that because I feel like maybe my immune system is attacking, just reacting very strongly to the visitor. That website does talk about type O and blood and infertility related to immune-related implantation issues. Oh yeah, I wanted to look at this. So I'm going to show you guys really fast. I got to stop sharing this one and share this one. We can look at this really quick. Okay, can you guys see that okay? Yeah. So let's see if I can find. So here's basically, it's these lovely little icons again that you will see on the test. Parental compatibility, HLA mismatches, natural killer cell, cytotoxic activity, systemic inflammation, autoimmunity, regulatory T cell, and thrombophilia. Immunological issues. So let's look at this. So here, for infertility, miscarriages, complications, and IVF failure. So that's definitely, I'm in there. Minimizes financial and emotional burden, a repetitive high cost, low success low success fertility treatments. Delivers more successful outcomes by determining appropriate immunological follow-up care. Here's the doctor.
Hi, I'm Dr. Vidali, and I think that one of the most frustrating situations in medicine is being told that there is no explanation for a problem. If you have been told that you have unexplained infertility, or have been told that your miscarriages are unexplained, or have been told that your IVF failures are unexplained, then the answer may very well be in the immune system. Physicians recognize the role of immunity in reproduction, but unfortunately, in many cases, they lack the expertise to order the right testing panels. Or if they do order the immune testing, they sometimes encounter difficulties in interpreting the test panels and also implementing the appropriate treatment. The PregImmune report represents a solution to this problem. Developed by a team of immunology experts, the PGM1 report can help you find the answers you deserve. The PregImmune report will provide your treating physicians and you with an exhaustive but also easy to read immunological analysis, evidence-based corrective actions.
Okay, I don't know about that easy to read, but you guys, the link I did put in the chat if you want to go. Oh shoot, if you want to go back to it. So these were the tests, and it is developed by him, which, like I said at the beginning, I did not know that. Oh my God. Hang on one second. I'm going to put you guys on hold. I have got to go to the restroom. Give me 1 second. You guys talk amongst yourselves. I'm going to play the streaming soon. Give me 1 second. Sorry. my goodness. Okay. The water. I've been drinking my water, but when it calls, it calls. I just realized you guys couldn't even see that video until I got back. Sorry about that. Okay. I starred some of these because I want to go back to these. I definitely am going to do some more research about the O and the O negative because now I'm curious about that. B Black, I've never bruised up from love knocks. You may not either. Okay, I like that answer. I just bruise so easily, but I think I'm going to numb. We'll see. Would love to get some input wisdom from you guys about my situation when there's time. Yes, there is time, Jennifer. Let us know what the situation is. Again, you can come. I'll post it. You can come and join me on screen and we can talk about it, or you can put it in the comments and we can talk about it. But I feel like with all the ladies here, you're going to get some good answers. Kitty, he's a great doctor. He encouraged me to get my endometriosis surgery. Oh, which one? Dr. Vidali or the CNY doctor? Did I miss it? Sorry. Okay. Where is this one? B. I've been thinking about trying to book with Braverman for testing. Do you recommend them? I think immunity may be a factor. We had a failed FET of our PGT euploid girl embryo. Oh, I'm sorry for your loss. I like them. I particularly like Dr. Thornton because I've had a couple of conversations with him, and he has a previous working history with my RE, so I like that. I feel like that can be shorthand in a way. If I could, I'm not a fan of the nurse that was assigned to me, but I mean, it's just, I could be high maintenance. I'm not willing to put that out of there, but even like the way the doctor explained to me in this video about these grams, that was the first time it made sense because I was like, okay, how many tablets do I need to take? And she would just go through, it needs to be 6, but then how am I converting it? Right. And I wanted to make sure because, 6 grams is what she wanted to get to, but I was trying to figure out if the one pill, which the doctor said it was 1 gram, because the serving size, well, you guys heard it. It was like a little bit off. At either rate, it's been a week because I started taking the 6. I met with him last week, Wednesday, which I think was the 13th. So it's been a week of the 6 tablets. I have 1 more week to go of 6 tablets a day, and then I will go down to 4. I just got a new bottle from Amazon. So yes, there's that. And I've been eating omegas, omega-3. So I had some salmon earlier. I did a Caesar salad and put salmon on top. I had some sushi last week with like yellowtail. I ordered salmon and yellowtail. So I'm trying to, I had avocado, but is avocado an omega-3 fatty? I already know what it is. Like my 6 is high because I was eating processed food like French fries and biscuits. For those of you guys over on Becoming Tanika, you know about my biscuit fetish. But yeah, I would definitely recommend them. I would say the testing is good. The explanations are good. I just didn't have a good time with the nurse. But that doctor gave me his mobile number. So I was like, okay, I'm in there like swimwear. I don't ever need to call that nurse again. I'll just be happy to send her emails. Yes, Elizabeth. So I wasn't sure if those count because I feel like part of it, your body recognizes it was pregnant. So, but again, I know in the first 3 months, there's not a fully formed placenta. It's not like you had, the full stretching of the uterus. So I think it just depends on like what exactly is happening as a result of the pregnancy that's triggering that. Because I mean, a miscarriage is still a pregnancy, right? So it's like, does it have to be fully like, in the same way that, God forbid, we had to give birth to a stillborn, that's still a pregnancy, even though you're not getting a take-home baby, right? And you still went through the process of birth. I just don't know if it's like because the placenta is not developed enough. Yeah. I agree, Angie. I feel like I should have at least explained, had the opportunity, especially because in my email to her, I said I wanted to speak to Dr. Thornton and I never heard from him. I don't know if she didn't relay it, so there's so many things, but it was like, and I don't have a direct number for him. But then she was like backpedaling in the email, like, well, I call you back and blah, 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 and you weren't available and blah. But I'm not in the business of being available, like from 9 to 5. I'm not trying to be difficult, but like if I call the dentist's office, I expect somebody to answer the phone during the business hours of the dentist. So I would expect to be able to get this nurse on the phone during the business hours of the business. So, but then when I wasn't getting straight answers from her, I was like, it's okay, it's fine. So I will have to call her once the cycle starts. So I'll be in touch with Nurse Katrina from Columbia and this other nurse. I'm not going to say her name, but the other nurse from BRI. And we'll be in lockstep as far as what's going on. Laura, part of advocating for the patient is to help in reducing costs of medicine or procedures, et cetera, if at all possible. And yes, you can change your diagnosis, i.e. headache might not cover CT, but head pain will. Oh, interesting. That's a good point. The thing is too, because I remember I had to take the girls to the vet when Liberty was going to get fixed, as they say, right? I can't remember, her liver enzymes were too high. And so the doctor wanted to do all this testing. Well, the dog insurance kicked it back because there was no diagnosis. So I'm telling the vet, you need to put a diagnosis on here or what you think you're diagnosing. She was like, well, just ask them what they want me to put. And I'm like, they've never seen the dog. They haven't done any lab work, any testing. Why would they want you to put anything? They want you to tell them the truth. Like, what is it you think you're testing for? Because at that point, then I'm siding with the insurance. Like, you're just doing random tests based on nothing. But yeah. So that's a good point that the diagnosis can be, which I imagine as you get more information, a diagnosis could legitimately change. Like, it's a science. Medicine is a science. You're always proving or disproving a theory. So you may have been diagnosed with something because the doctor thought this hypothesis fits. But then when new information comes and it no longer fits, then the diagnosis has to change. I just didn't like the aggression. I didn't like the trying to like talk me down, because when we're going through this, we're already vulnerable. I feel like everybody we talk to at the doctor's office should have more compassion, be a little more patient, but that's just me. So, this I wanted to highlight. I've heard the doctor I work for go off on insurance company during a peer-to-peer review and scream to them to show him their medical degree in order to make the decision to not cover a few diagnoses. Nice. Honestly, he didn't like doing peer-to-peers with insurance when insurance required them, so he would save them for Monday afternoons and take out his anger on those calls. LOL. It all can be aggravating for them and us. Nice. Okay. I think I might be a little sheltered because I don't talk directly to my insurance company. I think I've said this before. There's an intermediary that the company pays to talk to them. So I talk to the intermediary. Sometimes I get frustrated with the intermediary because I feel like they're not paying attention. Like when they were telling me I was all out of IVF coverage, but you have to have 2 egg retrievals and 2 transfers as defined by our policy. I know everybody, it can be different. But I had only had 1 transfer at that point. So I wasn't out. But the lady who called me back was like, oh, well, you've had 2 retrievals and 1 transfer. So yeah, you're out. I was like, no, but I also get 1 more transfer. Now I pay for the transfers out of pocket for the exact amount for the transfer, but they cover the, what do you call it? The ultrasounds and the blood work. So yeah. Oh my God. Heather Page, exactly. Kaiser refused to cover anything for my cycle, but cover my letrozole. Yeah. Oh, that sucks. They wouldn't cover anything else. A lot of times that the top reason why something would be denied is because of a lack of documentation. Yes. And I can get behind that. Like that's a straightforward answer. Right. And so, yeah, just start with that part. So, and the same reason why some clinics don't do things that don't have enough documentation. They're like, you guys get that sorted out, all that experimentation. But like, he was losing me when he was like, oh, there's no reason for them to look at the research because there's no money in it and blah, blah, blah. And I'm just like, what? If you say there's not enough documentation, that I understand. When you're like, there's not enough research because there's no money in it. Like, when is there not money in fertility treatments? Yes, he was not paying attention to me, Michelle's piece of life, because that he was squirming a little bit. So he recognized that my face was kind of twisted up, but he doesn't know me well enough to read it. And he damn sure didn't want to ask, because I'll do that on the thing. Like, I'll ask people, are you okay? Are you having a bad day? Not accusing them of anything, but like, obviously we're looking at our screens, our faces every day. So you can, when you are in the habit of seeing someone, you can kind of tell when they're like having a bad day. He was not trying to touch that with a 10-foot pole. He was doing a lot of like smiling and a lot of but I think because my face wasn't giving what he wanted it to give. So you said sometimes doctors frustrated me with that. Pay attention to your patients when you're explaining or going over things. I'm just saying, yeah, because how do you know if they're even tracking what you're saying? I think it's good to answer questions like ask questions like, does that make sense? Do you have any questions about that? Oh, you look a little bit puzzled. Like, tell me what you think I said. You know what I mean? Like, engage the person. But you know, we all have different. Listen, as long as he can get me pregnant, I'm good with all that. He don't have to read my face. Read this coochie. But yeah, he don't have to read my face. Yes, and a biopsy alone with surgery only tells you about that one spot they happen to biopsy. Like, a biopsy doesn't tell the whole story either. I hate when different specialists change fixed ideas. Yeah, definitely. And that's what I would say. If you see something on this ultrasound, it would make sense to go in where you're seeing it and biopsy that specific area. But yeah, it's one of those things of like, why mention it if we're not going to do anything about it? And maybe that's because I'm a person with anxiety, then I'm like mulling over. Oh wait, you added something to this. A biopsy alone with surgery only tells you about that one. Doesn't tell. I'm not following the correction, but I think I got the gist of what you said. Yeah, be consistent, because there's some information we know to be fact, right? And so then when they tell you something that is outside of that, it makes you question them, rightfully so. If for no other reason than to get a better understanding, like, this is the understanding I have, but now it sounds like what you're saying is different. Can you help me like bridge the gap in my understanding? So, oh, you're having internet issues. I'm glad you're back. I had to take a restroom break, so I can't fault internet issues. Oh, wait. Christina's getting a congratulations. I missed it. Shout out Red Lobster Biscuits. Yes, ma'am. Okay, wait. I've missed some of these because I was in the star. Oh, you had Dr. Vidali? Okay. So are you doing CNYM, Braverman Kitty? I have questions. I need answers. Shout out to Emily D. Baker. I have questions. So I unfortunately have an appointment that I have to leave for. Hope to get advice from you guys soon. Okay, Jennifer, we'll get you in another live. So you are welcome, B. Brown Eye Queen, what's going on? 2010, what's crackalacking? I found out that I have fibroids when I went for a CT scan of my digestive system. I hope that once I'm ready to have a family, I'll still be able to. I hope so too. Oh, that's interesting. So were the fibroids in your digestive, like, or they just spotted them while they were doing, those CT scans? Those are not fun. Red Lobster Biscuits. Yes, ma'am. Okay. Christina M. I started this journey at 34 years old. Kept repeating the same protocol before discovering my body was attacking the embryo. Success finally at 51 now and due in 6 to 7 weeks. Woohoo! Christina, that is the news that I needed to hear, ma'am. Because I'm 51, so that's good. And you're due in 6 to 7 weeks. I will be due at 52, but that's a whole other story. 34 years old. Wow. I will say we have not repeated the same protocol, but I think that also makes it more difficult because from when I had my own eggs, that was different sperm than when we went to donor egg, or I went to donor eggs and a different donor sperm. We did switch up the protocols, but I'm hoping the immunology is the one missing piece. So hopefully we find out that maybe my immune system is attacking the embryo. Yes, congratulations to Christina. This was the only transfer I added baby aspirin and Claritin 1 time per week for 12 weeks. I'm still on baby aspirin. Nice. I'm back. Okay. Neo Soul Rider. Hey, she's giving Christina congratulations. What's going on? You guys want to get down? Oh my God. Hey. Don't knock her out. Don't knock her down. Okay. Ugh. Are you guys done working for the day? They sit with me all day up here. There's 2 computers, my work computer, my personal computer. Justice thinks she can type. Let's see. Neo Soul Rider, we need to find a fertility coach and have that conversation with the fertility coach. Because I do have questions still. And now every time I see you, I think of that. Because I'm sure there are some fertility coaches who are not trying to just get the paper, but I just want to know how he was reacting. Yeah, he was nervous smiling, and doing just a lot of hemming and hawing, as we say back home. Read the writings on my walls, not my face. Oh my God. And he was all in my house. Oh, you have a nice color on that. Like, sir, are we here for an appointment? He was trying to get off on the good foot. He was like, let me compliment her. She looks serious. Oh, you talked to him on Instagram. Oh, interesting. Okay. They just spotted them. Who did they spot? Uh-oh. I don't know. Hey, Storm. Yay, you made it live. We're wrapping up here, but we're going to go through these questions and these chats and see. Started with my own eggs too before moving to donor eggs at 46. Nice. Okay. That is a hard turn. It's a hard turn to move to the donor eggs, but kudos to you for doing it sooner. I waited. Oh my God. I can't say I should have done it sooner. I don't know. I think I did exactly what I was supposed to do, but of course, hindsight is always 2020. I could reimagine it a million different ways, but I'm definitely glad that you have your baby and it's coming soon. It gives me hope. You have no idea. So would you like me to reach out to the coach that made the comment, then delete it? Yes, because I tried to find that coach and I could not. I could not find it. Red Blonde Chick, are you still in here? I'm trying to look out to see. I know I got the one message. I just want to make sure your messages are not disappearing. Oh, they spotted it while doing the CT scan. Interesting. Okay. So are they small enough that they don't have to be removed? Because I know I've seen it both ways. I've seen girls who do TTC videos say like the doctor was like, it's fine, leave it alone. And some are like, you have to have them removed ahead of time. I just wonder, like mine was 2 by 2 by 1 something. Is it still growing? Like, I'm trying to think. No, because I actually haven't had any medication since that. But so when this new cycle starts, I'll start the estradiol and we'll see. It is a hard turn moving into donor egg. I feel you. It took time. Yeah, it just takes. It's a hard turn. You're going to become a parent in a different way than what you imagine, and that is hard. And it also is like, how do I tell people? How do I tell the child? Am I going to feel less adequate? Are people not? Am I going to feel? Or am I going to be made to feel like? Are people judging me because I've gone to donor eggs? You know what I mean? Like all of that is in there, and just the grieving, especially after multiple miscarriages. Because part of it is I would just tell myself like next time it's going to work, and so I really, really thought. I won't go to donor eggs. I'm just, if it doesn't work with my own eggs, I'll walk away. But guess what? When push came to shove, that's not what my heart felt. So, I mean, and I say that like my heart, meaning I wasn't ready to walk away from being a mom again. So it just, even though it was a painful, hard turn, I knew that I had to make that turn, you know? And I imagine there are people who are like, no, that's too far. And I respect it. But before, when I first came into this, I never thought I would do donor eggs. I was like, that's when I walk away. Still here. You starting in August, which happens to be on my birthday. I will also be starting the same time, going for my second retrieval on August the 2nd, which is on my, oh, happy birthday. Oh my God. Yeah, my cycle should be starting around August 2nd, August 3rd, somewhere around. No, I take that back because there's 31 days. When was 4th of July this year? Was it on a Sunday or a Saturday? Because I started the night of the 4th, I think it was. I have to go look at it. But yeah, it'll be beginning of August. So I'm excited. I'm excited to be starting. Taking these pills and doing all the other stuff. But I'm telling myself, you got this. You just have to do. Okay. Did I miss anybody's comments? I don't see anybody who's coming up to talk. So I just want to make sure before we say goodbye that I got everybody, that I acknowledge you. I appreciate you all for coming through. Replay crew, I appreciate you. Anybody on the replay crew watching this later, drop a blue heart in the comments. Like I said, this video, just the video without the commentary will become, it's going to come out in like 10 minutes. Because I know some people don't like the talking with the videos. They just want to get the information, get in and get out. So I have no idea if they need to be removed or even what size they are. I found out about them by reading the report. Oh, they didn't even tell you? Oh my God. Okay. Wow. I'm glad you read the report. Hopefully they're small and not painful. I had my fibroids removed 5/27. Hey, Golden J, 1981. They thought it was only one intramural in the fundus. Ended up being 9 of them. 2 were the size of small plums, but not visible ultrasound. Wow. Wow. Well, I'm glad you got them gone. CNY wants me to do medicated cycles, then move to mini IVF. Medicated cycles that are not like an IUI, or medicated like timed intercourse and medicated cycles. I'm not sure I follow you. But okay. And I'm so confused, Kitty. I'm sorry. Are you also working with Dr. Vidali at Braverman, or you guys are chatting only on Instagram? Like a CNY and Braverman BRI, are they working together with you on this? Diva Girl D, hey. I'm glad you made it too, Tanya. I'm glad you liked the commentary. I enjoyed doing that. Hey, we get a blue heart from the live crew too. Okay, replay crew, if you're watching it, get the blue heart in there. Thank you. I like to talk and go through it with you guys because I feel like, I know we could do the premiere and we're all in there together, but then I get stuck trying to type. Like I want to stop the video, talk, and then play the video. So I'm glad you guys are liking the watch parties. Thank you for joining me. I think that's all. Hopefully I didn't miss anybody. Hopefully nobody's got randomly deleted. I'm looking from here because I'm in StreamYard. I cannot delete your messages. I can put you in a timeout or I can block you. But I know you're not blocked because I saw your message at the top. Yeah, you're still in here. Okay. Well, hopefully it's all sorted out now. All right, ladies. Thank you for hanging out with me. And I'll see you next time. Baby dust to us all.